entropion for that matter. The deficiency is the deficiency of your lid layers is the vertical. So the vertical. So the can you imagine if this is your lid and if there is vertical deficiency, of course, because this is shorter, the margin of your lid will be pulled outwards. Usually, the vertical deficiency is the anterior lamella. And the anterior lamella is composed of your lid, of your skin, and your subcutaneous tissue. So, most often it is the skin that is shorter. So, the lid will be pulled outwards.
Audio again, Doc. Yeah. Okay na, Doc.
So you divide your lid layer into lamella. So shortening of the anterior lamella will cause ectropion. Shortening of the posterior lamella will cause entropion. Okay. Can you imagine the lid margin? Can you still imagine the lid margin? The lid and the lid itself and the lid margin? Can you still imagine it? The layers? Wala na. Nawala na. Anyway. So, congenital tarsal kink, okay? It is just like a severe form of entropion. But this is the whole upper lid that is bent back towards your eyeball. And usually the eyeball is also malformed inside. Okay. Now, distichiasis naman is an extra row of lashes. Usually, lashes won't form beyond the gray line. You know what gray line is? The gray line is the part between your conjunctiva, okay? Your conjunctiva and your skin. Now, at the outer part are your... Ano ulit ang ating ano dyan? Oo. Ayan nga pala. Ating bullet. Okay. Okay. This one are your meibomian gland orifices. This one is actually your gray line, and they're not supposed to be there, because these are orifices. So these are lashes which are growing in an abnormal location. So this part here, these lashes there, of course it won't bend, it would bend outwards. It will bend towards your eyeball. So every time the patient blinks, these lashes will abrade or or irritate your eyeball. So kaya parating mapula yan. So the symptom, of course, because it's irritating, will be red, the eye will be red, and there will be tearing. Okay? Now, if the abrasion is just there, if the lashes are growing on the lateral half of your margin, of your lower margin, what if it grow at the middle? And now, if it is in the middle third of your lid margin, imagine if it is here Every time the patient blinks, it will now touch on your
Right.
cornea, eventually abrading it. Talaga, if the cornea will be abraded, this will be painful. Why is it painful again if this is abraded?
Nerve
Can you
supply,
still
Doc.
remember? Huh?
Innervation of
Because,
cornea.
yeah, the innervation will be exposed. Okay? So, now, uh, pinakamadali na management, of course, is you have to pluck one one lash at a time. And this will usually grow after a couple of months. So the patient will go back again. But in congenital dystichiasis, this one is really present. All the lashes are really present in all of the in in beyond the gray line. So what we do is we split this one, the lid splitting procedure. We split at this area, split, then remove this one, including the follicles, then suture this two again without this one na. So we remove this one, we split the lid margin, then we suture, we fuse again this one. Okay? That's the lid splitting
Doc,
procedure.
the question. So,
Mm.
will you operate, Doc, on one eye at a time, or will you do it if it's present on both eyes?
Uh, since this is in general anesthesia, this is usually bilateral in congenital dystichiasis.
So,
So we do this simultaneously. Okay? Mhm. So epiblepharon is this is common actually in Asians. It's a horizontal fold of skin adjacent to either the upper or lower lid, which may turn the lashes against the cornea. Okay. Now, have you seen the children? Ito, itong lash nila, itong lid margin, there is another fold there, nakaganon. In children in less than 3 years old, there is another fold of skin here, lalo na pag mga flat pa ang mga ilong. Okay, if their nose bridge are still flat, there's another fold of skin there. Parang the lid margin is exposed.
Doc, audio, Doc, nawala na naman. Oh my God.
Okay.
Okay lang.
This is common in Asian children, especially in less than 3 years old. You can see another fold of skin below the lower lid, which will run from here. It will fold here up to here in your medial canthus. And usually the children here have still flat nose bridges. Okay? So while uh, now if the lash will grow together with will bend towards the eyeball, we usually operate on that also. We repair the lower lid. But if it is not that severe, we just wait until the patient develops the nose bridge na. Kasi eventually, that that lash, the lid margin will just evert outwards. Okay? If it is not severe, but in severe cases, when both leads leads have this epiblepharon, and if this is disturbing the child, especially if there is tearing, redness, and secondary infections, of course, we need to operate on the child. Otherwise, if this is not severe, we just give them lubricants, maintain on lubricants, so that the cornea won't be abraded. Okay, parang just for the lashes to glide on your cornea or on your eyeball. Okay?
Apa, Doc?
Now,
Apa.
depending on the severity. Okay? Uriblepharon, this is the enlargement of the lateral part of the palpebral fissure. Uh, with downward displacement of the temporal half of the lower lid. Na? Instead na pataas, down. Tapos, the fissure is mahaba. Usually, pag mga bata, the fissure, adult, usually mga 27 millimeters horizontal. Bata is still mga ano pa lang yan, 25, 24, kasi bata pa yan, na? Okay? Yan. But in this ano, para silang mga alien na mahaba ito. Hmm? Okay. Parang alien nga, no? Mahaba. Okay? Mahaba ang fissure. Oh. This one naman, epicanthus, kanina, yung epiblepharon was in the lower lid. Kanina. There's another fold of skin here. Ito parang nga ito, oh. Ano, parang ganun din. But this one is a snow fold. Epiblepharon, you have two folds on the lower lid. Okay. This one is epicanthus. Okay. It's a crescent fold of skin running from the upper to the lower canthal area. This is your epicanthus inversus. Okay? Yan. This one is an uh, this is your, it has an inversus, and it has also as, it has from the lower uh, to the upper, parang they're joining on the medial canthal area. If you will see these children, akala mo duling, oh, di ba?
Yes, Doc.
Can you see that?
Yes,
Oh,
Doc.
oh. Normally, this is mistakenly diagnosed as esotropia. Huh? But look, if this is really esotropic, you have to pinch here on the nose bridge kasi hindi mo nakikita nga ang kanyang ano,
Yeah, canthus.
the you cannot see the sclera on this area kasi there is this fold, ha? This is this extra fold of skin that is covering your medial, the medial part of your eyeball. Wala kang nakikitang ano dyan, ni karungkol, oh. Diba? Oh. Now, this one, the babies here usually have flat nose bridges pa. Ha? So, you need not operate on this one. You just wait for them until na mag-ano yan, mag-mature. Oh, especially at 9 years old, develop na ang frontal bone. So, ang frontal sinus. So, magkakaroon na yan ng nose bridge. Ha? As long as the congenital anomaly does not cover the visual axis, you are safe to delay the operation. Basta free ang visual axis. Okay? This is epicanthus. This is your epicanthus palpebralis. From lower to upper. Both lower and upper. This one is epicanthus inversus. Okay? Telecanthus naman, there is a wide intercanthal distance. Oh, let's go back. Oh, akala mo ba wide ang intercanthal distance there? Itong batang to? Ha?
Yes.
If
Parang.
you will measure the, parang, because you thought na this is already the medial canthal area. Of course, no. That is just a fold of skin. If you will measure the medial canthal area, you have to examine first if you can see the okay, you have to examine first if you can see the sclera there. Ito hindi mo naman nakikita yan. Ha? So this is just a fold of skin. Underneath this fold of skin is your medial canthus pa. O wala ka namang medial canthus dyan. In measuring your interpalpebral distance, dapat from medial canthus to the other medial canthus, ito wala naman ang medial canthus mo dyan. Wala man. Nandyan ba? Wala, di ba?
Wala.
It is being covered. Oh, ito, meron. Yan, pwede pa. O, exposed siya eh. Ito, wala. So, you have to pinch it to see the medial canthus first. Doon mo lang masasabi na duling din ang bata. But this one, no, this is not isotropic actually. Pero meron, hindi yata. Nag-aano lang to. Although the reflexes are not the same also. Ito, parang duling to. Parang may isotropia. Because the reflex is here. The corneal reflex is here. It's not center. This one is center. This one is not. Parang may isotropia nga ito. So, may isotropia at the same time, may picanthus. Blepharophimosis complex. Ayan. There's epicanthus inversus. There is ptosis. Okay? And the palpebral fissure is shortened horizontally and vertically. Actually, may nakita na kayong tao siguro na ganyan. Yan o. Ptosis. There's epicanthus inversus. And the fissure is shortened horizontally and vertically. Dapat, pag ito na to parang hindi na ito, bata pa to, pero mga 7 na siguro ito. Yan. Ito maiksi. Yan. Para siyang maliit lang na nabutas dyan. But the lid fold here, actually, pero ito, hindi normal ang kanyang lid fold. Usually here, the defect is the levator function. That's a poor levator function. Ptosis, alam na ninyo yan. Okay. Ophthalmia neonatorum. You have rotated already in your Nico. Nico? So, what do you instill on the eye of the baby once it is born?
Erythromycin.
Erythromycin?
Yes,
What?
No, ointment.
Erythromycin ba?
It's prophylaxis.
Silver nitrate.
Silver nitrate.
Silver nitrate.
Until now, hindi na ginagamit yan taga saan ba kayo? Ha? You're already in the 21st century. Ha? Silver nitrate, hindi na yan ginagamit ngayon ha. Batukan ko kayo. Ibiarimsi! Boy, hindi na ha. Sobra kayo ha. Hindi na yan. It is already fusitalmic ointment ang ginagamit. Di ba? Nakita ba ninyo? Ha? Fusitalmic ointment ang ginagamit ngayon. Kayo talaga. Sumbong kayo ha. Parang silver nitrate ko talaga. Hindi na tayo nasa 90. Ginagamit pa yata yan sa noong 1970s pa. Kaya talaga. Sige. So, of course, any eye redness in a baby, it is labeled as ophthalmia neonatorum. Kaya lang, you have to know the virus. Bacteria, anong pinaka nakakatakot dyan? Neisseria. Okay, andali ha. Ayan. Now, can you still hear me? Okay. Why is it that an ophthalmia neonatorum caused by Neisseria gonorrhoeae is an emergency?
It could destroy the cornea.
Do you
and cause corneal erosion, Doc?
Not all bacteria can penetrate an intact cornea. Remember that the corneal barrier, the epithelium, is a very effective barrier for infection. Not all bacteria can penetrate your cornea. There are only few bacteria, and one of that is your Neisseria. Okay, the others are your Neisseria, Listeria, monocytogenes, your Legionella. Ano bang iba? 5 yan Moraxella. Isa. Diphtheria yata. Ano ba yung isa? There are only 5, but the most common is your Neisseria gonorrhoeae. Huh? So usually, na
Chlamydia.
the hallmark of your Neisseria gonorrhoeae. In a baby, what will you see? Even in an adult patient. Hmm? Hmm? There is profuse discharge, yellowish discharge talaga. Huh? And sometimes, may dugo pa. Huh? It is mucopurulent discharge. Huh? So, what will you do if the baby is positive for Neisseria gonorrhoeae? What is your what is the histologic appearance in your gram staining?
Intracellular
Inclusion.
diplococci, Doc.
Okay, that's your diplococci. Okay. So, uh, what will you do if you have a baby with this condition? Hmm?
Isolate the baby.
Of course, you will have to treat the baby. Okay, so you will refer to your pedia. Okay, uh, you have to give the topical and the injectable, ha? Parati yan. Parating, kasi emergency ito. You have to treat this well. Kasi once it will penetrate on the cornea, it will cause an ulcer. Okay? It will be, it could affect your vision later on. Okay? Now, where is the lesion? Okay? Where do you usually see the corneal ulcer in your Neisseria? In what part of the cornea? Diba? You have your central corneal ulcers, your peripheral corneal ulcers. Where do you see the lesion usually? It is in the periphery or on the center?
Center, no?
Hmm?
Periphery.
Hmm? The
Periphery.
periphery. The central corneal ulcers is commonly caused by
Chlamydia.
hmm? The bacteria that causes central corneal ulcers are usually Pseudomonas, Strep, Moraxella. Okay, peripheral, gonorrhea, Neisseria, and your staph. Okay? Okay?
Apa daw?
Mm.
Apa daw?
Yes
Mm.
po, Doc.
Okay. Now, if the baby is positive for Neisseria gonorrhoeae, you also have to treat the mother and the father. Okay. Kasi saan man nakuha yan ng baby?
It's both terms.
From the mother. O saan man nakuha yan ng mother?
From the far.
The father.
From the father. O see? So, if in if the patient is treated for Neisseria, the baby and both parents should be treated also, not only for gonorrhea, but also for
Chlamydia.
chlamydia. Okay? Kasi usually they go hand
In
in
hand.
hand.
Yes, Doc.
Yeah? Okay? So your patient is not only the baby, but both parents are your patients too. Okay? Yan. Okay?
Yes, Doc.
So, your trachoma. Okay. Now, this is the incubation period of your of your ophthalmia neonatorum. In chemical conjunctivitis, it quickly follows after installation. Usually yan ang silver nitrate. Kaya hindi na yan ginagamit. Ha? Kasi irritating yan sa conjunctiva. Ha? Then, in Neisseria gonorrhoeae, it is hyperacute with purulent discharge. Usually, mga 1 to 2 days nandyan na yan. Ha? Chlamydia, ito ang mga tagal-tagal. Minsan 3 days to 3 weeks of age na ang baby before magkaroon nito. Ha? So, the workups, of course, your gram stain, your GIMSA, then you have your culture. Okay? Yan. Ano na kayo dyan sa mga ganyan na mga treatment? Okay na? Nasa pedya na yan. Nasa pedya na. Okay?
Yes,
You
Doc.
always have to irrigate the eye. Clean the eye. Ha? Clean the eye always. Tanggalin mo ang mga discharge na yan. Hindi yung purang patak. You have to clean the eye with NSS. Okay?
Yes, Doc.
Yan. Your inclusion conjunctivitis, look ha, tetracycline is given for 8 weeks. Ha? Yan. Oral tetracycline. Yan. Then, nasolacrimal duct disorders. Usually, at birth, hindi pa nagluluha ang baby. Ha? Hindi pa yan.
Doc, warayan din, Doc.
Okay. Okay. At birth, kahit umiyak ang baby, wala pang luha yan. So you cannot expect to elicit tearing due to nasolacrimal duct disorders. It will take a few days before you will notice that the baby will be tearing. And if there is no punctum, there is no opening in the punctum, or there is nasolacrimal duct obstruction, you will only minsan nga, when the baby is about to be discharged from the nursery, doon lang ninyo nalalaman na luha ng luha may discharge. Ha? Kasi, most often, at birth, hindi pa talaga nagluluha yan. Wala pang luha. Yan. Now, the most common is the simple obstruction of your nasolacrimal duct. At birth, 80% of the babies, their nasolacrimal duct is not yet open inferiorly. Where does your nasolacrimal duct opens? Where does it drain? Huh? Huh? Where does your nasolacrimal duct drain?
Middle.
Inferior nasal meatus.
Huh? Inferior?
Nasal meatus.
Meatus. Okay. Now, what valve is covering that area there? What valve?
Valve of Hasner, Doc, or
The valve of Hasner, yeah. 80% of infants, the valve of Hasner is not yet open. So, most often babies have tearing. Yeah? But eventually it will open. So, it will just be, it is pathologic if the valve of Hasner won't open until the age of 6 months old. Okay? But oftentimes it will open within the first month when the baby is born. But if there is tearing or after a month, okay, bata, usually nauwi na ang bata, nauwi na, okay siya sa nursery. Then babalik sa'yo for follow-up. This time may tearing, may mga discharges na. Okay? That means the valve Hasner is not yet open, so you have to do massage. Kriegler massage. It's the Kriegler massage. Downward massage. Here on the medial, in the medial area. Here, downwards. 1, 2, 3, 4, 10 strokes down every day. Twice a day. Because when you apply the pressure on your lacrimal sac, Okay? You will be forcing the bulb Bussner to open. Huh? Okay?
Wala.
Now, you cannot expect the mother to especially pag mataba ang mother, kawawa naman ang baby, ang laki-laki ng kanyang index finger. Ha? Kasi maliit, the area there is so small. So you will be needing cotton buds to massage that. Cotton buds. Ha? The paper stem, ha? Paper stem cotton buds, not the plastic, masakit yan. Paper stem cotton buds. Downward strokes twice a day. Okay?
Kapada.
Until the bulb Bussner opens. Okay? But if the nasolacrimal duct obstruction persists until the baby is 8 months old, 8 months old to 1 year old, that's the time that you will have to do nasolacrimal duct probing na. Yun. Inaano na yun talaga. Pinoprobe na. Binubutas na lang after. Kasi after 1 year, after 1 year and 2 months, mahirap nang mabukas yan ng massage. So you have to do probing already. And beyond that, after 1 year and 2 months, even probing won't be effective anymore. So operation na yan. Acryocysto-rhinostomy. So diseases of the cornea. Okay. Now, what is the adult horizontal diameter of your cornea? Horizontal diameter. Adult, ha? Adult.
7 to 12 mm.
12 millimeters horizontally. Vertically,
11.
11. Why 11? Kasi 11. Hindi. If you will see kasi, the sclera is invading the cornea about 1 millimeter away from the limbus. Okay? So, in children, the horizontal diameter is only 10 millimeters. Pero pag megalocornea, sobrang ang laki. Mas malaki pa sa adult. 13 millimeters or more pa yan. Yan. Simple. No associated abnormalities. Keratoglobus naman can be part of your Ehlers-Danlos. Okay. There is generalized thinning and bulging of the cornea. This one, wala. Malaki lang talaga ang cornea. But the thickness is normal. Okay? Keratoconus, cone. It's just like a cone. Okay? When you look at the slit lamp, the anterior chamber would appear deeper because your cornea is shaped like a parang volcano. Actually, if you will do refraction, usually you will see a very high astigmatism at 180 degrees. The astigmatism here will usually exceed 300. Astigmatism at 180 degrees. Now, as the patient grows older, pataas ng pataas ang astigmatism until na hindi na yan makuha ng autoref. Now, because the cornea here is thin, especially at the tip of the cone, is thin, so sometimes it can be ruptured. The cornea can be ruptured by trauma. So this one, if you have a keratoconus, because the cornea is thin, you cannot do your LASIK. You cannot do LASIK in a keratoconus. It's either here you will do corneal transplantation already. Corneal transplantation. Now, this time you already have corneal bonding for keratoconus. it's already non-invasive. Unlike your your keratoplasty, your corneal transplant, hindi na, ha? Meron na ngayong corneal banding for keratoconus, ha? Parang tinitikan na ang cornea, ha? May ina-apply na chemical, then a light is para pa ring laser na mga technique, but not invasive na. Wala ka ng unlike laser na you have to slice the cornea, slice it, flap it, and do laser underneath. This one wala. It's just light. Chemical, then light. Na? But in severe cases talaga of keratoconus na nag-rupture na, of course, you will be needing corneal transplantation na. Ha? Yan. Microcornea. Okay. Here naman, the corneal diameter is less than 10 millimeters. Ha? Now, non-ophthalmos, the eye is small, but the rest of the parts of the eye is also small. The cornea is small, the iris is small, the lens is small, everything is small. And this eye, although small, can see. Yeah? In microphthalmos, the eye is small, but the other parts of the eye is not formed. They are malformed. They're not normal. Huh? The iris, the lens, sometimes are not normal. Sometimes there is opacity on the cornea. Huh? But in non-ophthalmos, everything is normal, but just a miniature of each of the parts. In microphthalmos, the eye is small, but the other parts are abnormal. Okay? So between the two, it is the non-ophthalmos that sees. The microphthalmos usually has a poor vision. Okay? Pediatric glaucoma. Okay? The presenting symptom usually is corneal edema in 3 months of age. Corneal enlargement in older children na. And the patient will usually manifest with tearing and photophobia. Huh? Okay. Yan. Okay. Usually, their cornea, their eye will appear as parang blue. Huh? Parang blue. They're blue-eyed. But they have tearing and they have large corneas. So, the lens disorder, the microspherophakia, yan. Okay, okay na yan. Okay. Leukocoria again. What is leukocoria? The white reflex. White reflex on your pupil. Where do you see leukocoria pa? Okay. Lensectomy. Lensectomy is different from your ordinary cataract surgery, huh? In lensectomy, you remove the cataract. Lensectomy is done in children. You remove the cataract, but you also remove the anterior vitreous. Because normally, in a cataract surgery, okay. Now, lensectomy is done in children because if you have congenital cataract, the anterior hyaloid face of the vitreous is also, there's also opacity there. So you have to remove the anterior vitreous together with the congenital cataract. Okay, that is lensectomy. Okay. Uveitis in the pediatric age group. The most common cause of uveitis in children, what is uveitis again? Inflammation of what? Huh?
Uveal.
Of the uveal tract. So what are the parts of the uveal tract? Anteriorly. What is anterior?
Iris.
Iris. Next.
Ciliary body.
Ciliary body. Next.
Vera.
The
Alright.
choroid. The choroid. Okay. So uveitis in the pediatric age group is uncommon, and usually the frequent cause is trauma. So just like your adult uveitis, the main management pa rin is your cycloplegics and steroids. Okay? Wala namang difference yan. Now, your ROP, tandali ha, tingnan ko. Okay. So, your retinopathy of prematurity, okay? You still call that retrolental fibroplasia in your pedia, ha? It is retinopathy of prematurity na, ha?
Apa daw?
Abnormal vasoproliferation in premature infants. Okay? These are usually the predisposing factors. Of course, the birth weight of less than 1,500 grams, less than 28 weeks age of gestation, respiratory distress syndrome, prolonged oxygen exposure, and multiple births. Okay? Yan. They theorize that oxygen can obtund the development of the peripheral blood vessels in your retina. That is why they develop abnormally your blood vessels at the periphery of the retina, causing now your abnormal fibrovascular proliferation at the periphery, and sometimes extending to the equator. This one, the stage 2. Stage 2 meaning there is already this one, there is already volume. Meron na siyang there is fanning. Ito wala pa yan wala pang the periphery of the retina has no vascularization yet. Hindi pa nakaabot doon. So when the patient is exposed to oxygen for a longer period of time, this one, the blood vessel here will grow abnormally. Parang fanning, parang nagfa-fan dyan. And this will usually, sometimes they bleed, they leak, so they will cause detachment on this area. There is the demarcation line. So the initial fundus examination usually is 4 to 6 weeks after birth. Now, premature infants are very difficult to examine because their iris dilator muscles are not that developed yet. So mahirap silang i-dilate. So even though if the patient had been born at 27 weeks, mag-aantay ka muna ng at least 4 weeks bago mo siya ipa-initial examination sa ophtha. Wag agad-agad. Dapat you have to stabilize the patient first. Okay. Now, if retinoblastoma is the most common intraocular malignancy in children, what is the most common orbital malignancy in children? No idea. Di ba ako nag orbit? Ako, di ba?
Yes, Doc, I think.
What? You forgot na. Don't ever interchange the two. The most common intraocular rhabdomyosarcoma. So, tinanong na niya si Google. You ask Google. Okay. Don't interchange the orbital, meaning inside the eyeball. Okay. Lateral in 30 to 35% of cases. And usually, sarcoma, the average age of diagnosis is 7. 7 years old. Huh? This one is 1 year, mga 1 year and a half to 2 years old. Huh? Na, history talaga. There is usually this one. Lateral, mas malakas ang transmission. Huh? Mm-hmm. Yan. These are the presenting signs. Leukocoria. Leukocoria, kitang-kita mo yan paggabi. Ha? Parang cat's eye. Cat's eye. Cat's eye reflex. Ha? Why? Why at night? Why do you see this at night?
Kasi mas dilated, Doc, pag gabi.
The pupil is dilated, and because this is tumor, the retina will appear as white. So, makikita mo yan, para siyang cat's eye. And of course, because the vision is not similar on both eyes, is the other eye has a poor vision, the patient will have strabismus. Huh? Of course, you have visual difficulties. Huh? Itong mga red painful eye, itong mga ano na to, pag may secondary glaucoma na, may seeding na. Huh? Orbital inflammation and proptosis, ito na yung mga advanced na stages. Ha? Pag leukocoria na, sa loob pa lang yan ng mata, yan pang maganda. The patient can still be saved in that, yeah, that stage. Yan. Flexner-Wintersteiner rosette. This is the pathognomonic histologic finding in your retinoblastoma. Yan. Yan, ang mga ano ninyo. Tandaan ninyo yan sa board exam. Yan, yung mga histologic findings, ha? Okay. Now, usually, in CT scan, you will see calcification. Calcification. Ha? Yan ang ano sa CT scan ng retinoblastoma. Calcification. Pag sa histopathologic findings, Flexner-Wintersteiner rosette. The other non-specific histopathologic histologic findings, your rosette formation, your florets, you have rosettes, but the pathognomonic is your Flexner-Wintersteiner rosette. Okay? Yan. Yan, Homerite rosette, yan ang mga mga findings. Yan. Sites of metastasis. Of course, pinakamalapit dyan is your skull bones. Then your distal bones, spinal cord, lymph nodes, and your viscera. Of course, you have to see the patient pa sana early. When the tumor is still intraocular, because you can still save if the lesion is still small, you can still save the eyeball and you can still save the eyesight of the patient, especially if the tumor is still small and at the periphery. If it does not involve yet the macular area, you can still save the vision. Now, kung malaki naman siya, and it will be needing enucleation already, you have to remove the whole eye. If the tumor has not extended beyond your optic nerve, you can still save the patient, the life of the patient. Yan ang pag hindi pa siya mag-extend optic nerve, the survival rate is very good. Until adulthood, meron pa kaming patient ng boss ko dati. Nakita na opera siya at the age of 4 yata. Tapos and my boss was already ilang taon na ba matanda ng boss ko. And that patient was already a medical student. Talagang, although she only have one eye, but the other eye was okay. So, okay na siya ngayon. Doktor na yan siguro. Kasi early. The treatment was early. And the operation was early. Now, trilateral retinoblastoma, this is when your pineal gland is already involved. Yan. Can you see this one? The workups, the treatment. Okay. You read through that. Now, bilateral retinoblastoma talaga. Usually, we don't operate on them already. Usually, they need chemotherapy. Pero kung maliit pa man, you can, photocoagulation can be done. You can still salvage the eye and even the vision. Kahit lang isang mata. But this will need chemotherapy talaga. Kaya lang, the survival, the prognosis is not really good. Not good. O, dito na tayo. Ocular motility. Okay, can you still remember this one? Sige, look at that again. So most of your extraocular muscles is supplied by your oculomotor nerve. So the rest is 4 and 6.
LR6, SO4, R3.
Yeah. LR6.
SO4,
The levator is included in your extraocular muscles. That's your 7. Okay. So let me see. So the primary position of the eye. Okay. Now, that is the position in which your eye is directed straight ahead, with the head also being straight. Okay. The primary action of the muscle is the major effect on the position of the eye when the muscle contracts while the eye is in primary position. For example, primary position, nakatingin ka diretso. Tapos you will see, you abduct the eye. Abduct meaning out. Okay, out. Abduct to the left. Abduct to the right. Yun ang ano. So, during lateral gaze of the left eyeball, so what muscle would that be on the left? Lateral gaze to the left. Lateral gaze of the left eye.
lateral rectus.
What muscle is that? The lateral rectus. Yeah. The subsidiary action naman are your secondary and tertiary actions of the muscles in addition to the effects on the eye in its primary position. Look, Yan. Yan talaga, dapat yan minimemorize. Ano?
Yes.
Dapat talaga yan minimemorize. Memorize mo na yan. Dati. Straight. Sige. So, all your look all muscles originate from your ausin. Yan ang muscle cone. Your muscle cone. The rest, your oblique muscles, okay? Although your superior oblique, inferior of lacrimal fossa, behind your lacrimal fossa. Your levator is still apex above annulus. Yan. This one naman will form the anatomic insertion of your recti from medial to lateral, lateral, superior, medial, inferior, going to lateral, then superior. What's that again? That's your spiral of the low. The spiral of the low. Tillaux. Spiral of the low. Okay? That's medial, 5.5.5, 5.5, inferior, 6.5, 6.9, 7.7. Palayo. Okay? So, look at the medial rectus has only one action, only adduction. Your lateral rectus has only abduction. The primary okay, your superior rectus, the primary action is elevation, the secondary action is intorsion, the tertiary is adduction. Now, ito again tayo. Let's talk again. You get nga ano, ask Nikki for a scissor. Let's go to your scissor again. Do you still remember the scissor?
Yes, Doc.
The vertically acting muscles. What are the vertically acting muscles again? The superior rectus, inferior rectus, superior oblique, inferior oblique. Okay?
Wala.
Wala dito ang medial rectus. Ha? Wala. Okay. For oh, I only have Doktora Kalipayan. Who was not under me before, huh? So I don't know if this was okay, this is how I make my students understand. Okay, this is your scissor. Imagine this is your inferior oblique, superior rectus, inferior rectus. Okay. Now, move back. Okay, I'll move back. Okay, this is your inferior oblique, superior oblique, superior rectus, inferior rectus. Okay. We are talking about the tertiary action of your vertically acting muscles. Okay, vertical, ha? Look, if you close this one, okay, if you close this one, where did this one go? Is it going, where will this go? The two recti muscles.
Medial, Doc. Oh.
Towards the, papunta sila pareho. Pareho sila. Ito palayo. Ito sila palapit. Pag ganun sila. Okay? Yan. So, that means, both your recti muscles will go medially. So, they will adduct. Okay? They will adduct. And the oblique muscles will go laterally. Ito yung ilong. Ito yung ilong. Okay? Ito,
Kailan
ilong
mo
ito,
break
ilong.
up? Tapos,
Ilong.
nagtas.
Okay. So, ganon. So, palapit yung dalawa, ito palayo. Okay? So, the oblique muscles will
Lateral, Doc.
abduct.
Okay.
Yeah, they will abduct. The recti muscles will adduct.
Okay.
That's your tertiary action. Okay? The tertiary action of your vertically acting muscles. Okay? Now, the torsional movements are the primary action of your oblique muscles. Torsion. Torsion, hindi yan pag ganito, pag ganito. Ito yung ganon. Ha? Yung, ay, kahirap. Wala
Parang
tayong bola
ikot,
dito.
Doc.
Ah,
Parang ikot.
torsion. Torsion. Walang bola eh. Wala tayong maliit na bola. Pwede. Ikot. Torsion. This is here be looking, makikita mo yan sa slit lamp through the limbus of the cornea. Kasi gumaganon. Gumaganon. Intorsion, extorsion, pag ganon, pag ganon, pag ganon na ano, naghahanap pa si Patrick ng bola. Okay. Now, it is because of their insertions. Remember, malaki ang bola doon, ni Nicky, malaki, sobrang laki. Now, remember that this is due to the torsional movement is brought about by their insertions. So, the oblique, the superior oblique, the functional origin is at the trochlea. Okay? So, the insertion of your superior oblique is beyond the equator of your orbit. So, if that superior oblique will contract, okay, it will contract, it will move the eyeball down and medially. Ha? Pag ganun, gaganon ang cornea. So, makikita mo yan sa corneal, sa superior. We usually look at the superior part of the cornea. It will do like that. That. Okay. Now, the inferior oblique naman, the insertion is here at the inferior part of your orbit, but it is medial to the equator. So, pag nag-pull yan, gaganon ngayon ang eyeball. Pag ganon. Yan.
Extortion.
No. The superior oblique, it will do, ito pala, beyond pala, sa may temporal to the equator, beyond the equator, but temporal to the orbit, tama, to orbit, to the eyeball. So, it will rotate pala internally. Okay. Pag ganon, ang superior oblique, superiorly siya, ha? Ano ba naman ito? Ating mga ganito na lang. Ito, siguro naalala ninyo ito. Maybe you can remember this. That all the recti muscles adducts. So, if the recti muscles adducts, the opposite of that, the oblique muscles will abduct. Okay? Now, only for the vertical, ha? Now, for the torsional movements, okay? All the superior muscles will intort. All the inferior muscles will extort. Yun. Okay. Ganun na lang. Yung rods na wala tayong mata dito. Pala explain sa Okay. So, yun na lang. Kahit anong... Okay? Yan. So, what if your lateral rectus is paralyzed? What will be the position of your eyeball?
Medial. Okay. Actually,
So, what will be the tropia of the patient?
in
Itropion.
in
Extropian.
Iso.
Eso.
Isotropia. Exo is going out. Na? Iso. Kasi, wala na naman. Wala naman.
okay pa daw, okay pa daw.
Okay.
Hello.
Iso is going in, exo is going out. Huh? So, if your medial rectus is paralyzed, what will be the tropia now?
Ano daw?
If your medial rectus now
Exodoc.
Exodoc.
Exo.
Makontak ka.
Adak.
abduct. Okay. Oh, ayan na yan. Yung spiral abdomen. Okay? So, from the superior rectus, it is farther from your, this is your limbal area. So, the farthest from your limbal area is your superior rectus. Then, the medial rectus has the nearest insertion to your limbal area. Now, the medial area of your eyeball is the common location of your pterygium. So when you do pterygium excision, you have to be very careful because you might cut the medial rectus. If you will cut that one, hindi mo na makikita yan. Bigla yan nagko-contract. You cannot find that one anymore. Because when we do muscle surgery, we clip this one first before we cut. Okay? You have to clip that one. So these are the blood supply. Mga things to remember. Yan. Ito na yung inaano ninyo. Ito yung, this one yung the cardinal position of gazes. Ito na, ha? Yan. If you will examine one eye